So what we're doing here is we're continuing our MCQ discussions in cardiology. And let's finish off valvular heart disease, endocarditis, congenital heart disease, arrhythmias, and if you are up to it, pericardial, this pericardial is so those are the MCQs that I sent you. So let's focus on the MCQs, I think. SCQs we can do later once we finish off the MCQs, right? Last week we did heart failure. So one more session of cardiology next week, and then that's done. And then we can do more regular sessions because your professorials are finished and you're in study leave. And we can do sort of more regular sessions a week after that. Hari? Okay. Hari. Right. So if you take the first MCQ in the sort of valvular congenital heart disease paper first, we'll finish that off and then go to the other one. Okay. Right. So the first question is on aortic stenosis. Okay, so that's the first question. Now, aortic stenosis is a very, very important valvular heart disease, and it's quite common. Okay, and you will definitely get a question based on this. And also, you are definitely going to find this in your short cases. So it's very important to know theoretical details about it. All right. And please, if you have any questions, you can switch your mic on and ask, or you can put it on the chat. Okay, I'm looking at the chat. So if there's any question, put it there, or switch your mic on and ask. Or you can raise your hands also to make it a mic on. Okay. So the first statement here is based on the etiology of aortic stenosis. Okay. Okay, so let's talk a little bit about that. The statement is calcific aortic stenosis is associated with coronary atherosclerosis. Okay, right. So so the most important thing to understand is that aortic valve stenosis has a very close relationship with atherosclerosis. It's very close relationship with atherosclerosis, and it has a very similar sort of risk profile. Okay, very similar risk profile, and there is a very, very strong association with coronary atherosclerosis and aortic stenosis. Now, I have given you some figures here, which you can have a look at later on, how this occurs. But essentially, they are sort of the same continuum of disease. Okay. And there's, as you can see in this statement, there's a very strong correlation of valve calcification and calcification of the coronary artery. So it's the same sort of atherosclerosis calcification process that occurs in the aortic valve. And this is the most common cause for aortic stenosis. You can write down, if you like, that rarely you can have congenital causes of aortic stenosis, right? Congenital causes of aortic stenosis, that's rarer. But this calcific aortic stenosis related to atherosclerosis is by far the commonest etiology of atherosclerosis. Okay. Aortic stenosis is known to present with exertional syncope. That is the second statement. Now, if you look at the various presentations of aortic stenosis, there are a few key things that you need to remember. Number one, they can present with exertional chest pain or angina. Why do they present with exertional angina? In aortic stenosis, they have very severe left ventricular hypertrophy. Okay, they have very severe left ventricular hypertrophy, and the muscle mass is increased dramatically. Now, this muscle mass, the blood supply sometimes is inadequate to supply this big muscle mass, the hypertrophied left ventricle. And also the left ventricle, when there's a lot of muscle, the tension inside is very high also, right? The muscle tension is very high. And the blood flow can be interrupted, especially during systole. Okay, so two reasons then. The aortic stenosis causes left ventricular hypertrophy. The muscle bulk is increased, so there's more demand for blood flow, more demand for oxygen. And also the massive tension that builds up in that muscle cuts off the blood supply. So they present with exertional angina. That's one thing that happens. Another key presentation of aortic stenosis is syncope, and this is partly due to an inadequate cardiac output when the aortic stenosis becomes tighter and tighter and tighter. Okay, and that is another feature that we see. So the second statement is true. right? Another thing that can happen is they can present with heart failure, right? They can present with heart failure also, right? And if they present with heart failure, please write that down. That is very, very severe, very, very severe aortic stenosis, right? They present with heart failure. That is almost end stage aortic stenosis, end stage aortic stenosis. Hari? Okay, so this is correct. Syncope, exertional angina, heart failure are the key manifestations of aortic stenosis. Okay. Okay. Harita balanne. Is that clear? Okay. Right. The next thing is easy. We have done this in our short cases, short case classes, and naraka makeup hila tiyanava. So this typical slow volume, low volume, slow rising pulse is very key. And also I might have told you, at least almost all of you, them group but almost all of you I taught that another key feature of severe aortic stenosis is this carotid thrill. Carotid thrill is a feature of severe aortic stenosis, carotid thrill, and of course the slow rising pulse. Another thing which is closely related to this is a narrowed pulse pressure. Narrowed pulse pressure, right? Why is the pulse pressure narrowed? Because the systolic pressure drops because of low cardiac output, number one. Number two, the aortic valve is narrowed, so the resistance to flow is also increased, right? And the diastolic pressure goes up. So the pulse pressure becomes narrowed, right? Narrowed. So these are some of the physical signs that you see in aortic stenosis. Right? Now, the fourth and fifth MCQ statements here are focusing on the management of aortic stenosis. And all of you know that if your patient is symptomatic, what are the symptoms again? Exertional angina, exertional syncope, heart failure, any of those symptoms with signs, so there are signs of heart failure, symptoms of heart failure, they need very, very urgent intervention. Urgent intervention. Right? And please write this down. If you don't intervene in these patients, so patients with symptoms or signs of heart failure, so symptoms of exertional angina, syncope, symptoms and signs of heart failure, if you do not do anything for them, the mortality rate, right, is about 50% in 1 year, right? So that is a massive mortality rate, right? Every one person in two will die in 1 year if you don't do anything. So that's how severe the mortality is in these patients. If they have symptoms, if they have heart failure, please do something for them. Refer them immediately to cardiology for some sort of intervention, which I will talk about in a minute. But the mortality rates are close to 50% in 1 year. Massive mortality rates, massive mortality rates. Okay. So LV dysfunction is an absolute contraindication for aortic replacement is false, right? It is a high risk surgery, but yes. Right. Okay, now what sort of interventions can be done? So patients who have symptoms need intervention. Patients who have symptoms and signs of heart failure need intervention. What sort of intervention? Aortic valve replacement was a standard intervention that we do up to now. But now we have a new sort of thing called TAVI. මේක මම figure එකක් දාලා තියෙනවා TAVI කියලා. So this is a non-invasive or minimally invasive method of replacing the aortic valve, and these sort of figures are self-explanatory. මෙතන මේ balloon එකක් වගේ goes in, and then you have the valve, you dilate the balloon, and then the valve sits on the aortic valve. This artificial valve thing sits on the aortic valve. So that's called TAVI. It is done in Sri Lanka. And it is something that we use to manage aortic stenosis quite often now, right? Those days, it was only aortic valve replacement, right? But now we have this minimally invasive method. At the moment, it is used for people who cannot undergo aortic valve replacement, who have some sort of contraindication, but is gaining popularity. Stents wage tamai lamai. Now, in cardiology, those days, everybody had to have a bypass surgery. Now people are having more and more stents. There are some people who still need bypass surgery, but minimally invasive methods have gained popularity. Similarly, TAVI might gain more popularity in the future, right? It is done in Sri Lanka, not very often, but it can be done. So then the message here is if they're symptomatic, they have signs of heart failure, you need to intervene. There is no doubt about that. And fourth statement is wrong. It's not an absolute contraindication. It is an indication actually for aortic valve replacement or TAVI. Dekama karanna puluwan. Right. And then balloon valvotomy is just putting a balloon and dilating the valve. That is not recommended. That is not recommended in aortic stenosis management. You do that for mitral stenosis, but not for aortic stenosis. The reason is the risk of restenosis. So if you do balloon valvotomy, the replacement, the risk of restenosis is very, very high. Right? Very, very high. So that's not recommended. Right. Okay. Hari, any questions from this? Before we move on to the other one, another thing you need to remember, Lamai, is that even in patients with asymptomatic aortic stenosis, right? So even if they don't have any symptoms, still there might be a need to intervene, especially if they have asymptomatic, if they are asymptomatic but have echocardiographic features of heart cardiac dysfunction, right? So low ejection fraction, for example, right? Or if they have, you can also measure their transvalvular aortic gradient, right? If the transvalvular aortic gradient is the pressure difference across the aortic valve is high, that also might need intervention despite them being asymptomatic. Right? But remember that even if they're asymptomatic, there are other things like the ejection fraction, their transvalvular aortic gradient, they will need intervention. Right? Okay. So Pratibha is asking if patients have multiple complications addition to heart failure can be due to any cause. We have ischemic heart disease and aortic stenosis. So that is again a very sort of specific judgment call, Pratibha. You have, of course, it has to be a sort of cardiology person making that decision. It's sometimes difficult, right? Because what Pratibha says is, yes, there's aortic stenosis plus other complications, other heart failure risk factors. How do you know what is causing the heart failure? But those sort of things are more advanced decisions, right? Right. So let's move on to the next one. So the next question is based on mitral stenosis. Right? Mitral stenosis. And the first statement is on etiology. Right? First statement is on etiology. Right. Okay. So mitral stenosis is most often due to rheumatic valvular heart disease. Is absolutely right. That is, say 99% of mitral stenosis is due to rheumatic valvular heart disease. Okay. There is no doubt about that. Again, there is a very small proportion of patients with congenital mitral stenosis. Okay, very, very small proportion, but 99% is due to rheumatic valvular heart disease. Okay. Now, then statement 2 and 3 are more clinical questions. So as you know, mitral stenosis, what happens is you get increased left atrial pressure. That is what happens when there is mitral stenosis. The pressure in the left atrium increases. Pressure in the left atrium increases. So here the left atrial pressure increases. And then this increased left atrial pressure is transmitted into the pulmonary venous system. That's what happens. So if increased left atrial pressure is transmitted into the pulmonary venous system, which gives rise to pulmonary edema. Gives rise to pulmonary edema. That is what happens. You get pulmonary edema. And they get the symptoms and signs of pulmonary edema. Placing. That is what happens. With time, now this is also very important, the pulmonary edema can be, the pressure in the pulmonary venous system can be transmitted onto the pulmonary arterial system, causing pulmonary hypertension. So pulmonary hypertension is also a complication of mitral stenosis, right? So because this increased pulmonary venous pressure with time, long-standing increase can be transmitted onto the pulmonary arteries, causing pulmonary hypertension. So pulmonary hypertension can be a complication of mitral stenosis. Right. Now, what happens is when you have this increased left atrial pressure, the left atrium dilates. And if you remember your anatomy, another unusual feature here, as you can see, is the left atrium can press on the recurrent laryngeal nerve. The anatomical diagram on the right here shows that when the left atrium dilates, it can press on the recurrent laryngeal nerve, and that causes hoarseness of voice. Okay, that causes hoarseness of voice. That is what the MCQ is asking about. And if you look even in this picture, you can see this. Okay. So here is the left atrium, left atrium, right? And you can see that the main bronchi are splayed. Splayed can add velati, So that is because one, this left atrial dilatation is pushing them apart, right? And it's also compressing the recurrent laryngeal nerve. So that is caused the hoarseness of voice. So the second MCQ here is right. Can present with hoarseness of voice. It is called, I'll put it on the chat, Ortner's syndrome. Ortner's syndrome. This hoarseness of the voice in mitral stenosis. And sometimes in very severe cases, they can get dysphagia also because it can press on the esophagus, which is posterior. Features in now, statement 3 is about the severity of mitral stenosis. Now, there are two ways of looking at the severity, right, of mitral stenosis. One is by actually the pulse. Now, if the mitral stenosis is very, very severe, very severe, the pulse volume starts to drop, right? Because the cardiac output starts to drop when the mitral is very, very severe. So the pulse volume reduces. So low pulse volume is a feature of tight mitrals, very severe mitral stenosis. Because the filling of the left ventricle is reduced, the cardiac output goes down. So that is a low volume pulse, right? The other thing is this opening snap business, which I have taught you. So in mitral stenosis, if you look at this slide, mitral stenosis, you have this one there, S2 there, and then you have this opening snap. Opening snap, that is the sound that you get when the mitral valve opens. Mitral valve opening sound, opening snap. Right? So this is the sound you get when the mitral valve opens, and you get this sort of mid-diastolic murmur. Mid-diastolic murmur. And remember, mid-diastolic murmur with pre-systolic accentuation. Pre-systolic accentuation. Now, what happens when the mitral stenosis is bigger, more severe, is that the left atrial pressure is very high, very high. Left atrial pressure is very high. So, the opening snap comes earlier, right? Because the high left atrial pressure is pushing open the mitral valve earlier than usual. So it's pushing the mitral valve open earlier than usual. So the gap between the second heart sound and the opening snap is shorter. මෙතන මේ දෙවෙනි pitch එක තමයි තියෙන්නේ. So shorter. යොලුකට පේන්නේ නැහැ, but it's a very subtle difference, but you can see that. So what is the basis then? When you have very severe mitral stenosis, the left atrial pressure is very high and it opens the mitral valve earlier than usual. So therefore, the gap between the second heart sound and the opening snap is much shorter in severe mitral stenosis. Right, that is the description. So make a වැරදි නේ directly proportional නෙවෙයි, inversely proportional. So time shorter the time, the more severe the lesion. Shorter the time, so more severe the lesion. Right. Now write down another thing about the opening snap. The opening snap will not be heard if the valve is very sort of calcified. If the mitral valve is very calcific, you won't get the opening snap. It's very calcific, it doesn't move. So it's immobile. When the valve is calcific, it doesn't move very much. So you won't hear a good opening snap if the valve is calcified. All right. Okay, fine. Any questions about those clinical things? So they can get pulmonary edema, pulmonary hypertension, hoarseness of voice, unusual feature. MCQ and then this opening snap S2 katava you need to know very well, even for clinical. Now in the clinical exam it's unlikely you'll hear the opening snap, but we might ask you this sort of a theoretical question even in the short case. Okay, fine. Then question number 4 going into is sort of management. Yes, you can. It's difficult. Sometimes you can hear the opening snap in AF, but it's very difficult sometimes. Yeah. Okay. But definitely you won't get presystolic accentuation in AF because there is no. So presystolic accentuation is because the last part of ventricular filling, the atrium contracts, pushing blood into the left ventricle. Right. If there is AF, that does not happen. Yeah, but in AF you can hear the opening snap. It's a bit difficult to figure it out clinically, but you can. If you're experienced enough. Right. Now here for all patients with MS and AF should be offered anticoagulation වැරදි on principle because you have to obviously look at the contraindications. හැම patient anticoagulation දෙන්න බැහැනේ. That is false. But most patients with AF and MS need anticoagulation. Most of them, unless it is strictly contraindicated, there is a very high risk of stroke. If you have MS and AF. So unless there is some big contraindication, almost all of them, not all of them, but almost all of them will have some anticoagulation. Right? Okay. And at the moment, the guidelines recommend warfarin, right? Even where alut oral anticoagulants, new or novel or right? Those are also not indicated for mitral stenosis AF, right? Warfarin tamai that there is evidence and is recommended. Right. Okay. Then patients with severely calcific mitral valve. So then the next thing is we're talking about management here again. So PTMC කියන්නේ මොකද්ද? PTMC කියන්නේ is sort of percutaneous transseptal mitral valve commissurectomy. ඒකෝගොල්ලෝ දන්න එක essentially you put a sort of a balloon like thing into the right side of the heart, pierce the atrial septum and go to the left. So ඒක heal කරගෙන යන්නේ. ඒක heal කරගෙන යන එක දැකලා තියෙනවනේ. ඒක නිකන් බයනක නිකන් අර මේ ස්ක්‍රූප්පුවක් වගේ එකක් දාලා heal කරන්නේ. හරි? ඒක දාලා heal කරලා it goes on to the left side. And then you dilate the mitral valve. So that's called PTMC. Now, in order to do PTMC, there are certain things that you need to do. The valve should be mobile. Valve should be mobile and non-calcified. You can't dilate it, right? If the valve is not mobile and calcified, you can't dilate it. It's so thick and stiff, right? So that is something that you need to remember. Also, if there is mitral regurgitation, severe mitral regurgitation on top of mitral stenosis, you can't do PTMC because you'll just make the regurgitation worse. So patients with severely calcified mitral valves or very thick, stiff mitral valves are unsuitable for PTMC because you put a balloon and dilate it. The valve is very stiff and thick, you can't dilate it. The other thing, contraindication for PTMC, which might appear in MCQ, is if you have associated mitral regurgitation, then also it is contraindicated because the moment you dilate the mitral valve, the regurgitation will get worse. That is the reason. So that is about mitral stenosis. Any questions from that?
Sir, if we do the PTMC, sir, do they invariably get MR, sir?
They can get a bit of MR, yes. So for a few days, they will get a bit of MR, but then it usually settles after that. Yeah. It doesn't last for long, but dilate karavu gamma, you can get MR, yes. For a few days, maybe. Hari, any other questions? Right. So let's move on to the next one, which is on aortic regurgitation. Right. So aortic regurgitation, the first thing is again etiology. Is known to occur in patients with Marfan syndrome. That is, it is a famous thing. Yes, definitely. Yes, true. Hari. And here I have given you some other causes of aortic regurgitation. Right? Aortic regurgitation, acute or chronic. Acute or chronic aortic regurgitation. Right? So just study some of them. Remember, in a connective tissue disorder, collagen-related disorder like Marfan syndrome, you can get aortic regurgitation. It's a collagen-related problem, connective tissue collagen-related problem. There are similar other things like Ehlers-Danlos syndrome, that is again a collagen issue, can get aortic regurgitation. Now, aortic regurgitation occurs in a lot of rheumatological diseases also. And we learned this, in this spondyloarthritis, sort of aortic regurgitation is a known extra articular manifestation. So when we're doing spondyloarthritis as a long case, I told you that you can have aortic regurgitation as an extra articular manifestation, right? So ankylosing spondylitis and all the other spondyloarthritis, you can get aortic regurgitation. Okay. Now, in aortic regurgitation, as you know, you get an early diastolic murmur in the aortic area. And this third MCQ is talking about a very specific murmur, which is called Austin-Flint murmur. Austin-Flint murmur. Now, Austin-Flint murmur is a feature of severe AR. Austin-Flint murmur is a feature of severe AR. Now, the other important feature of severe AR is a wide pulse pressure, which is bigger than the diastolic pressure. So I think I've told this to you before. If your pulse pressure is wide and bigger than the diastolic pressure, that is a feature of severe aortic regurgitation. Severe aortic regurgitation. Right. Now, let's talk a little bit about this Austin-Flint murmur because that is the third MCQ statement. Now I'll draw this. So in aortic regurgitation, you get the regurgitant jet going like this. This is the mitral valve. That's the mitral valve. So this jet can press against the mitral valve in diastole. And it can sort of close off the mitral valve transiently because the jet can hit the mitral valve, closing off the mitral valve transiently. Right? That can cause a mid-diastolic, you could get in mitral stenosis, a mid-diastolic murmur in that region. Now, this is an echo, right? And you can see this. So, this is the left atrium. So, aortic regurgitation, this is the mitral valve. And you can see this. Narrowing turbulence. So, that is the Austin-Flint murmur, and this occurs when there's a very big aortic regurgitant jet, right? Very big regurgitant jet. Okay, so that is a third MCQ. Right. Now, another thing that you can be asked about aortic regurgitation, there are a whole load of sort of extra cardiac or peripheral signs of aortic regurgitation, and nail grid pulsations are a feature, is true, right? Okay. And so here I've just given you a list in this of all the sort of peripheral signs of aortic regurgitation, right? All the peripheral signs. And historically, aortic regurgitation was first described in syphilic aortitis. Well, syphilis was there was a lot of syphilis in the sort of 19th century in Europe, and that was sort of the initial manifestations of presentations of aortic regurgitation. Syphilis caused a calcification of the ascending aorta and aortic regurgitation, cardiac syphilis, and the whole load of peripheral signs here, just for your interest, Harry. And as you know, Abraham Lincoln had aortic regurgitation, and he had a lot of these peripheral signs, right? Okay. So nail bed capillary pulsations are also called Quincke's sign. Okay. Okay. A high volume hyperdynamic pulse wave is typically seen in patients with acute aortic regurgitation. Now, this is an interesting question. In acute aortic regurgitation, you might not get a good hyperdynamic collapsing pulse because it is very acute. The physiological or pathophysiological changes are not very commonly seen. Right? Because of the reason, you take a little bit of time for the changes to occur to cause a sort of collapsing pulse and all these sort of structural changes in the heart and the vessels. So it might not be a acute feature. In acute, you might just get the murmur, nothing else, right? Even the heart is not enlarged. As you know, in aortic regurgitation, the apex is displaced. Acute because it takes time for the structural cardiac changes and the vascular changes to occur. Okay. So that is about aortic regurgitation. Management nothing really specific about that. Any questions? Any questions, Palantino? Okay. Okay, right, Hari. Right, so let's now move on to mitral regurgitation. Mitral regurgitation. Mitral regurgitation. Okay. So again, we're talking about etiology in the first MCQ statement, right? Right. So the commonest cause currently for mitral regurgitation is myxomatous degeneration of the mitral. That is very clear, right? So myxomatous degeneration of the mitral valve is the most important cause for mitral regurgitation. So that is true. Other causes, again, mitral regurgitation can occur in collagen-related connective tissue disorders like AR. So the causes overlap. Causes overlap. Mitral regurgitation also occur in relation to rheumatic valvular heart disease as well. You do that. So that is the first MCQ. Now the second is also very easy. Pansystolic murmur which radiates to the axilla. Yes, true. And here I need to tell you something additionally also. and I taught this to you in your short case classes, when there is a isolated leakage of the posterior leaflet only, so mitral regurgitation, sometimes you can get where the posterior valve leaflet is predominantly leaking. Not the whole thing, it's just the posterior valve leaflet. So please write that down. That is a special instance where the murmur can actually radiate in the opposite direction towards the left sternal edge and along the left sternal edge, right? That is when the posterior leaflet is leaking only, right? So it can the radiation occurs in the opposite direction, right? Okay, right. So එක පොඩ්ඩක් එතන ලියා ගන්න. Right. Can lead to right heart failure again is very simple to understand, because similarly, even in mitral stenosis, so this flow chart shows you this. So mitral stenosis, left atrial pressure and all of that I told you. And with long-standing left atrial pressure increase, there is pulmonary venous pressure increase, and there is pulmonary hypertension. Similarly, Lamai, in mitral regurgitation, because there is a lot of blood going back into the left atrium, the left atrial pressure increases again. So left atrial pressure increase, right? Blood from the left ventricle, a whole load of blood is going back into the left atrium. And the left atrial pressure increases, and then that gives rise to increased pulmonary venous pressure and pulmonary hypertension. The pulmonary hypertension can cause right heart failure. So that MCQ is right. Right? Back pressure into the left atrium pressure increases, then that increases the pulmonary venous pressure, then that leads us to pulmonary hypertension, and then heart failure, right heart failure. Right. Okay. Okay, right. Now the next two MCQs are based on, right, so this is, next two MCQs are based on the management of mitral regurgitation. So very simply, if they are symptomatic, so if they have features of any symptoms, usually shortness of breath, or they have heart failure, right, you need to intervene, right, if they are symptomatic. Even if they are asymptomatic, there are echocardiographic parameters like the ejection fraction, like the amount of regurgitation might indicate some intervention. Right? So if their regurgitant jet is massive, or they have low ejection fraction, right? You need to intervene, even if they are asymptomatic. Okay. And then what do you do? Valve replacement is essential. So that statement is false. You can repair the valve or clip the valve using a sort of minimally invasive method. You don't always have to go and replace the valve. Right? So that, because of that, that is false. Right. Essential, it is, you can do it, but there are better minimally invasive methods. Okay, minimally invasive methods. Okay. පස්වෙනි එක එච්චර වැඩක් නෑ. එක කපලා දාන්න එක පොඩ්ඩක් සැර වැඩි ඔයගොල්ලන්ට. Don't worry about that for the moment. හරි? If you are interested, it is true, and that is to reduce the peripheral resistance, and then sort of it improves the cardiac output a little bit, but ඒක වැඩක් නෑ. ඔයගොල්ලන්ට ඒක පොඩ්ඩක් සැර වැඩි. හරි? Okay. Right. Okay, so that is mitral regurgitation. So I think we have covered the important valvular heart diseases now. Any questions? From those questions. Okay, right, no questions. So let's move on to endocarditis then. So again, the first statement here is based on epidemiology. The incidence is highest in injection drug users. Now this is false. Injection drug users or sort of IV drug abusers, that group is actually being superseded or hospital acquired endocarditis. So now actually I think about 20% of endocarditis is due to hospital acquired stuff, and also these various cardiac implants and things that people put in, devices into the heart, long lines, IV lines, those sort of things are about 18 to 20% of endocarditis is due to that now. Right? You get this in sort of people who abuse intravenous drugs also, but now the biggest category now is related to hospital lines, cardiac sort of devices, that sort of thing related to endocarditis. Right? Right. Most commonly affected valve is the aortic valve. Okay. That is the next one. Most commonly affected valve is the aortic valve. Okay, ඒක පොඩක් බලා ගන්න. ඒක දැන් මටත් මතක නැහැ. උත්තර. මේක මම ගිය අවුරුද්දේ හැදුවේ මටත් මතක නැහැ. පොඩක් please research. Anybody who found the answer to this? ඔය epidemiology දේවල් මතක නැහැ මට දැන්. Yeah, please just refer එක ඕන තැනකින් හොයාගන්න පුළුවන්. හරි. Okay. Fine. Right. Now the next third MCQ statement is asking you about the sort of peripheral stigmata of infective endocarditis. Peripheral stigmata of infective endocarditis. Right. So here this picture gives you some pictures that show you the peripheral stigmata. So all of you know splinter hemorrhages, right? Janeway lesions, right? Osler's nodes, which are usually painful. Osler's nodes are usually very painful, right? And you can get various sort of subconjunctival or conjunctival hemorrhages. And another thing I've not shown you are rot spots in this slide. Rot spots that you see in the retina. Rot spots. Right. Now, splinter hemorrhages in the nails are pathognomonic. The word pathognomonic is a very strong word. Strong word. Like English, but very strong word. What pathognomonic is means it's anivaryam related. So if you find something, it is definitely infective endocarditis. So if you have splinter hemorrhage, that is definitely endocarditis. It's wrong. Splinter hemorrhages can occur in various other conditions, including vasculitis. Right? So that is not pathognomonic. Pathognomonic anivaryam splinter hemorrhage is surely endocarditis. That is not right. But you need to know for various MCQs, for your short cases, all the peripheral stigmata of infective endocarditis, right? Okay. Now, another etiology-based question is the statement number 5. Enterococcal endocarditis is known to be associated with bowel cancer, right? So, enterococcal or streptococcal bovis endocarditis, right? Both have been associated with bowel cancer, right? Dekama hari, Streptococcus bovis is a classical organism, but also enterococcal endocarditis is dekama bowel cancer associated. That is true, right? You can get enterococcal endocarditis also in sort of a catheter associated endocarditis, which is rare. Urinary catheters, you can get enterococcal endocarditis. That's important. All right. Now, the fourth last statement in this MCQ, prominent murmur may be absent in patients with right-sided endocarditis. Now, that is true. Why is it true? Because very simple thing. So, if you have endocarditis on the tricuspid valve, you get tricuspid regurgitation, right? Now, the basis for this being true is that on the right side of the heart, the pressures are very low. It's a low pressure system. The right ventricle is a low pressure system. The left ventricle, the pressures go up to 120 or more. But the right ventricle, the pressures are around 20, 25. So whatever regurgitation that occurs, there is a very low pressure system. So the murmur is softer because it's a low pressure system, and sometimes you might not even hear a murmur. So in general, not only in endocarditis, right-sided, especially regurgitant murmurs are lower in intensity because it is a low pressure system. Right. Any questions? So this MCQ gives you sort of a epidemiology, etiology sort of approach, and also some clinical related features in endocarditis. All right. Okay, right. Now, the question number 6 then, exploring a little bit more etiology, it also gives you some management related statements here. Okay? මේ ඔක්කොම MCQ වල පිළිවෙලට හදලා තියෙන මේ past papers මත් නෙවෙයි, but sort of පිළිවෙලට so that you cover the topic, right? So Staph aureus endocarditis, dry V drug uses, definitely yes, that is absolutely true. Okay? Apart from that, you can get other skin related staphylococcal organisms, right? Right, skin related staphylococcal organisms can also cause endocarditis. So coagulase negative staph එක ජාති තියෙනවා. So staphylococcus in general can cause endocarditis, IV drug uses, right? Okay. Pesara, tricuspid regurgitation is not a loud murmur, Pesara, so I was saying. So when because it's a lower pressure system, the tricuspid regurgitation is a soft murmur. It's not a loud murmur at all. Sometimes you don't hear the murmur. Yeah. So yes, I was talking about staphylococcal organisms, or yes, other coagulase negative positive staph can cause any type of staph in the skin can cause endocarditis in IV drug. Because when they inject the IV drugs, they introduce their skin organisms into the bloodstream. Right. Now, as you know, in endocarditis, the diagnostic criteria is the modified Duke's criteria. That is the diagnostic criteria, modified Duke's criteria. Now, in general, the modified Duke's criteria has an echocardiographic criteria, right? Echocardiographic criteria, and also a blood culture related criteria. Now, it is not necessary for you to know this criteria by heart. That's a useless exercise. But you should know that there is a blood culture related criteria and an echocardiographic criteria for diagnosing endocarditis. Okay. And from that blood culture criteria, there are some organisms that cause culture negative endocarditis. Culture negative endocarditis. There is a group of organisms which you call the HACEK, H-A-C-E-K, HACEK group of organisms that are culture negative. And also Coxiella is a famous culture negative endocarditis organism. Coxiella. There are other blood culture negatives which are not very common, like Mycoplasma endocarditis, but Coxiella is a very famous blood culture negative endocarditis. So Coxiella endocarditis diagnosed by positive blood culture is false because it is classically culture negative and you need to use serology to diagnose it. Serological diagnosis. Other examples are Mycoplasma and also this HACEK group of organisms. HACEK group of organisms. Then within the echo criteria, the first line is transthoracic. First line is transthoracic. But, right, transthoracic echo can see vegetations, regurgitation very nicely. But actually, transesophageal has a higher sensitivity and specificity. Higher sensitivity and specificity. Because it goes very close to the heart through the esophagus. It has a higher sensitivity when compared to transthoracic. So transesophageal has a higher sensitivity. Make it in අනිත් පැත්තනේ මේ statement එකේ තියෙන transthoracic හොඳයි කියලා. Transesophageal has a higher sensitivity because it comes close to the heart. Now you might argue ඇයි දෙයියනේ එහෙන එක මේක මුලින් කරන්නේ නැත්තේ. මුලින් කරන්නේ නැත්තේ it is invasive නේ. Transesophageal is invasive. මේක ඇතුළට දාලා බලන්න එපා, right? So if you can diagnose something from the transthoracic, no need of doing the transesophageal නේ. So, but the transesophageal has a higher sensitivity because it comes closer to the heart. Right. Okay, so tuna වැරදි. Empirical antibiotics should be started in all patients following first set of blood cultures. That is true. That is the treatment. So broad spectrum intravenous antibiotics. Okay. Now, how you take these blood cultures also slightly controversial. First set කියන්නේ අපි සාමාන්‍ය එකපාරට තුනක් විතර ගන්නවා. දැන් තුනකින් ideally එක. හැම වෙලේම කෙරෙන්නේ නැහැ, but ideally you should take it from 3 different places. Yeah, but there's a lot of sort of practical problems in taking these blood cultures in that way. Okay. Hari, now about prophylactic antibiotics. Hari, මෙන්න මේක තමයි මම ඔයගොල්ලන්ට මේ තියෙන මේ culture negative endocarditis causes මේ coxiella, chlamydia, brucella වෙන ලිස්ට් එකේ තියෙනවා, mycoplasmat මේ ලිස්ට් එකේ තියෙනවා, right? So these are all culture negative organisms. Right, now this is very important. When do you give prophylaxis for endocarditis? Right, so please remember these, very important. මේක මේ වගුව මතක තියාගන්න. මේක මේ දෙන්න නැති ඒවා තියෙනවා, දෙන ඒවා තියෙනවා. Right, so you give endocarditis prophylaxis and usually dental procedures, invasive dental procedures තමයි strong recommendation එක තියෙන්නේ. හරි. So what are these situations? If they have a prior history of endocarditis, yes, you need to give prophylaxis. If they have a transplanted heart, which is not a very common thing in Sri Lanka, valve disease in a transplanted heart, definitely yes. If they have unrepaired cyanotic, වචනේ බොහොම වැදගත්, cyanotic congenital heart disease or incompletely repaired congenital heart disease, right? So that is any congenital heart disease, incompletely repaired or unrepaired cyanotic congenital heart disease, yes, you need to give them prophylaxis. If they have some prosthetic material in the heart, yes, you need to give them prophylaxis. And this, the strongest evidence is with invasive dental procedures, and the drug we use is amoxicillin. So prosthetic valve material or prosthetic material inside the heart, right? Unrepaired cyanotic congenital heart disease or any incompletely repaired congenital heart disease, right? Heart valve in a transplanted patient or prior history of endocarditis, right? These are the indications for prophylaxis. And the strongest evidence is with invasive dental procedures. Invasive dental procedures. All right. Any questions? So, have a pre-existing valvular heart disease patient the prophylactic antibiotics? No. Lankana Samata there, but it is not the recommendation. And remember, at the MCQ, you are supposed to know the theory, not what we do, theory. There is a reason for that. But yeah, this is a theory. Okay. Theory එක තමයි MCQ එකට හරිය. ලංකාවේ කරන්නේ මොකද්ද නැත්තේ, ඉන්දියාවේ කරන්නේ මොකද්ද නැත්තේ කියන එක නෙමෙයි. This is the theory. These are the guideline recommended indications for prophylaxis. Hari, please remember this. Okay, අනිවාර්යෙන් MCQ එකට අහන්න sure. Hari. Okay. Right. Right. So I have given you a few MCQs on congenital heart disease. Now remember, congenital heart disease is mostly a pediatric topic, and you will see pediatric sort of MCQs in much more detail. Hari. So I've just given you one MCQ on that because it's not a very common thing to ask, and easy. So ASDs are usually asymptomatic, is correct. That is obvious, right? Okay. Right bundle branch block is seen in ECG in patients with ostium secundum defects. Yes, you can see sort of a left axis deviation and a right bundle branch block on the ECG, right? That is what is commonly seen in ostium secundum ASDs. මේවා නිකන් මතක මේවා විතරම දෙන දේවල් නෙවෙයි, ඒකයි මම මේ ටික ඉක්මනට කරන්නේ. Rib notching is seen in coarctation of the aorta. I've given you an X-ray of this. මේ rib notching තියෙනවා ඔන්න දෙන coarctation වල. And also you can get this is called the figure of 3 sign. ඔහොම aortic knuckle එක හරිය ඔන්න ඔය වගේ නිකන් අමුතු හැඩයක් එනවා, right? And we have talked about aortic coarctation of the aorta in relation to young hypertension also, right? අපි ගැන කතා කරලා තියෙනවා. Right. Now, tetralogy of Fallot is a cyanotic congenital heart disease. And will you ever get a loud second heart sound due to pulmonary hypertension? In tetralogy of Fallot, no, definitely not, because there is pulmonary stenosis. In tetralogy of Fallot, there is pulmonary stenosis. So you will not get a pulmonary hypertension in that. And another MCQ here, fourth one is also true. Pediatric TOF can be associated with coronary artery abnormalities is true, right? You can get this various aberrant coronary artery arterial abnormalities in tetralogy of Fallot. Okay, so congenital heart disease is not a common topic in a medicine paper, but you can get it in a pediatric. Definitely, you will get an MCQ in a pediatric paper. Right. So that is it. I won't discuss the SCQ because it's focused on the MCQs first, I think. Any questions? Congenital valvular heart disease. Not only from today's discussion, but if you have sort of come across other MCQs also when you were doing MCQs. SBR question. Sorry, I forgot that. What was the question?
So there was a case given about infective endocarditis and...
Let me check that. Wait. Right. So the question was, all right, nikang endocarditis, mitral valve replacement. Yeah. So this question is sort of asking you about organisms causing endocarditis in valve replacement patients. Right. So in the first month, within the first month after valve replacement, staphylococcal organisms are the commonest cause of endocarditis. So then 4 is the answer there. So within the first month of valve replacement, staphylococcal organisms are common. Later on, say then it sort of becomes like a normal valve, right? So, but in the first month, definitely there is no doubt that it is Staphylococcus aureus, epidermidis, and all these staphylococci are what cause endocarditis. Okay. Okay. So let's move on then to arrhythmias. Right. Now, during our emergency medicine classes, we have talked about arrhythmias, and this is just going to be an extension of those discussions, Hari. And some things that I didn't touch upon when we were doing that, those emergency classes, Hari. Right. So cardiac arrhythmias, as you know, you classify them based on heart rate to tachy or brady. And also you can classify them based on where the pathology of the arrhythmia commences from. Patanganne where it starts off from. So therefore you have sort of supraventricular tachyarrhythmias, which are most often narrow complex tachyarrhythmias. And also the ventricular where the arrhythmia arises from the ventricles. So you can classify it based on the site of onset also. Now, in an acute medicine setting, for the tachyarrhythmias, I have taught you another classification, which is narrow complex, broad complex. Right? So just remind yourself of those before we go on to the MCQs. Right. Now, this ECG is sort of the focus of the next few MCQs, and one of the most complicated arrhythmias to manage sometimes is atrial fibrillation. I'll talk a little bit in detail about atrial fibrillation because it sometimes confuses people, right? So atrial fibrillation, okay, right. And atrial fibrillation is a narrow complex tachyarrhythmia because it arises from the atrium, obviously. And the classical features here are irregular QRS complexes, irregular QRS complexes. And also, the P waves are not clearly seen, and there is sort of an irregular, wavy sort of baseline to the on the ECG. So irregular wavy baseline, no identifiable P waves, and a sort of a irregular QRS complex. That is the typical feature you will find on the ECG. Right. So let's go to the statement here. Statement number 1. So the first MCQ is based on etiology and occurs as a consequence of acute alcohol excess. Yes, true, plus long term. Acute long term use. So both are true. Right. And in the next slide, I have given you all the causes of atrial fibrillation. So anything in the heart can cause atrial fibrillation. There is no doubt about it, right? Anything in the heart. Plus, non-cardiac right? So alcoholism, acute alcohol excess plus long-term alcohol use. And there are lots of other things like, which I have listed here. Thyrotoxicosis, yes, here, hyperthyroidism. Pulmonary embolism can also sometimes present with AF. Right. And on the sort of graph on your left, you can see that the incidence of AF dramatically increases with age. Right? Dramatically increases with age. And especially beyond, I would say, the age of 65, there is a massive rise in the rates of atrial fibrillation. So second MCQ statement asks you, the incidence increases with age. That's absolutely right. Incidence definitely increases with age. Like a hurry. Sawtooth P wave is characteristic. Sawtooth P wave again, atrial flutter, not in atrial fibrillation. As I have shown you here, atrial fibrillation is an irregular baseline without obvious P waves. Atrial flutter may can you see this is sort of a slowish atrial flutter, but you can see the sawtooth P waves in atrial flutter very clearly. So it's the sawtooth P wave causes a completely irregular pulse with regularizers with exercise. Now that is false. Now if you take AF, the clinical manifestations when you examine the patient is a completely irregular pulse or an irregular pulse. Now there are other things that can cause a irregular pulse. What we describe is multiple ventricular ectopics. Multiple ventricular ectopics can sort of mimic atrial fibrillation. Mimic karanna puluwa. Mokada atrial ventricular ectopic ena velawak apita predict karanna bෑ. It comes at whenever it wants to come. So multiple ventricular ectopics can mimic AF. They can mimic AF. AF wage හැසිරෙන්න පුළුවන්. Mimic karanna පුළුවන්. Right? But the main difference is ventricular ectopics disappear when the person exercises or exerts. Even නැති වෙලා යනවා. Atrial fibrillation එහෙම නැති වෙන්නේ නැහැ. Right? So cause a completely irregular pulse which regularizes with exercise කියන එක වැරදි. It's false. Okay. And obviously, all of you should know AF is a very, very strong risk factor for stroke and TI. That is another very important clinical manifestation as well as a complication. සමහරට අපි දන්නේම නැහැ patient stroke එක එනවා and then we diagnose the atrial fibrillation. Right? So it can be it's a very strong risk factor for stroke and TIA. So this is sort of clinical related MCQ. Causes tika මේ table එකේ තියෙනවා. Age itself is a risk factor, as you have seen here. And then you have, right? So age is a risk factor, as you can see, and you have a long list of causes that you need to remember. Okay. Hari. Now this second MCQ, and best response MCQ 1, all are based on, and 2 I think as well, yes. All are based on managing AF. Right. Now managing AF ගැන අපි කලින් කතා කරලා තියෙනවා. Right. In emergency medicine, I taught you this. Cool. Right. This. Right. Emergency medicine. So this is acute AF management, right? Acute AF management, right? Right. I'll come back to this, but today I'm going to focus a little bit more on non-acute, chronic නෙවෙයි, non-acute. හදිසියක් එන්නේ ක්ලිනික් එකකට එනකොට හරි මොකක් හරි අපි හොයාගන්න එක. Non-acute presentation, non-acute presentations. So let's talk about these flowcharts. Right. Right. Now, in a non-acute presentation of AF, non-acute, where you say in a GP clinic, you diagnose AF, or you come to some other thing and you diagnose AF, non-acute presentation. The first thing to remember, Lamai, is that rate control is the first line treatment strategy. Rate control. Now, all of you know that there are 2 options for AF management. Rate control, rhythm control. So if we come with a non-acute AF presentation, rate control is the first line strategy. Unless මෙන්න මේ කරුණු පහ තියෙනවා නම්. Right? AF has a reversible cause. Patient has heart failure thought to be caused by AF. The AF is new onset and that can be proven, clearly new onset. Flutter තියෙනවා නම්, flutter is a different story, right? I'll talk about that later, flutter, right? If මේවා තියෙනවා නම්, you go for a rhythm control strategy, right? Reversible cause. Heart failure due to AF. New onset AF, right? Or atrial flutter and fibrillation. But atrial flutter is a little difficult to rate control. Right? Those sort of people are suitable for rhythm control strategy, right? As first line treatment. Right? Remember that. Okay, right. Now, fine. Rate control strategies, beta blocker is the usual drug that we use, like bisoprolol, metoprolol, or calcium channel blocker, right? Calcium channel blocker. Digoxin can also be used in people who are sedentary. Also, in patients who have heart failure, we can use digoxin. Patients who have heart failure, you can use digoxin. Right? So that is something that these are the drugs that we use for rate control. Right? Monotherapy is better. So beta blocker or calcium channel blocker or digoxin. Digoxin becomes sort of monotherapy when they have heart failure or they are sedentary or they can't use the other options. So that is what you use. Of course, if they don't respond to monotherapy, then you add on to other medications. Like if they're on a beta blocker, you can add on a calcium channel blocker, or you can add on digoxin. Okay. If the rate control strategy fails, right, then of course you have to go for rhythm control strategies. Right? Rate control strategy. Rhythm control strategies. Right? Okay. And also there is another new technique called ablation. Ablate karanna puluwang pathways. That is more high advanced sort of strategy management. Hari. And make a any questions about this? So this is a non-acute chronic presentation of AF. And remember, in that situation, rate control is the best unless you have any of these things that I mentioned in the first box, and then you offer them rhythm control, right? If you're doing rate control, monotherapy is better. Options are beta blocker, calcium channel blocker, digoxin. Digoxin, special drug, if they are sort of have heart failure or they are sedentary, you give them digoxin. Otherwise, I don't know, sedentary can මොකද digoxin වලට මේ patient exercise කරනකොට එහෙම ටිකක් අමාරුයි heart rate control කරගන්න with digoxin. That's why sedentary කියන එක තියෙන්නේ. Minopressant target heart rate is about 80 to 100, right? That is a target heart rate for rate control. If the rate control fails, then again you can consider rhythm control strategy. Hari? Okay. Fine. Hari. So these are the rhythm control strategies that you have. Right? So rhythm control karanne මොන වගේ අයටද? If the AF has a reversible cause, there is heart failure which is definitely due to atrial fibrillation, new onset AF, right? And hasn't been there for ages and ages and අවුරුදු ගණන් තිබිච්ච නැති ඒ වලට, or failure of rate control. Failure of rate control strategies, right? Okay. Okay, right. Now, rhythm control strategies, right? Rhythm control strategies differ if they have paroxysmal, indala hitla yana ena AF, right? Indala hitla yana ena AF, or persistent AF. So persistent is more long-standing AF. Digatama thiyena. Right? Digatama thiyena. AF, persistent AF. Okay. So if you are going for a rhythm control strategy and they have persistent AF, if the duration is more than 48 hours, right, which is most often the case, and they are not on anticoagulants can nathi kenek nan, right, then you need to do something like this. Maika pahadili karanna. What you do is you do a transesophageal echocardiography guided cardioversion. That is one thing you can do. මොකක්ද ඒකේ කරන්නේ? ලෙඩාට then these all stable patients coming to the clinic can refer to cardiology. Hari? Acute presentation නෙවෙයි මේ කියන්නේ. That's what I said, right? And so non-acute presentation කියන වචනේ පැහැදිලිව ලියා ගන්න. Non-acute presentation. So non-acute presentation, rate control first line unless they have any of the indications for rhythm control, or they are contraindicated for or they are not responsive to rate control. Right. Then if they have persistent AF, what is the primary rhythm control strategy? If number one, they are not on therapeutic anticoagulants, what you do is you take them into the echo room, do a transesophageal echocardiography, right? Exclude left atrial clots. So why transesophageal? That is what looks at the left atrium very carefully. The lasanta pain or left atrium, and you can see clots, right? If there are no clots, you can do the cardioversion then and there. එතනම cardioversion කරන්න පුළුවන්. හරි, එතනම cardioversion කරන්න පුළුවන්. Right? And this is usually electrical cardioversion. Right? Or if you don't have the facilities to do that, then you can just put the patient on anticoagulation for about 3 weeks, get them down and do the cardioversion. Right? So if you don't have transesophageal echoes වගේ තිබුණ නැත්නම්, you give them just anticoagulation දෙනවා සති 3ක්, ask them to come back and then cardiovert them, right? Then cardiovert them. Right. If they are already on anticoagulants, lazy, you can just give them cardioversion then and there. එතනම කරන්න පුළුවන්. Right? එතනම කරන්න පුළුවන්. හරි, එතනම කරන්න පුළුවන්. හරි. ඒක තේරුණාද බලන්න. Any questions about this arm of the algorithm? මේක ඔයගොල්ලන්ට හරියට මම හිතන්නේ කොහෙදවත් උගන්ලා ඇති කියලා. ඒකයි මේ මම හැමින් උගන්වන්නේ. The chronic AF, the long sort of non-acute AF management ගැන මේ උගන්වන්නේ. හරි. So for non-acute AF, rate control, first option, unless they have any of this, right? Rhythm control is offered when they have either those indications that I mentioned or the rate control fails. Rhythm control, the strategy differs if they have persistent AF. This is how you do it, right? Mostly their duration more than 48 hours. If they are on anticoagulants, you can do it then and there, electrical cardioversion. If they are not on therapeutic anticoagulants, you have to do either an echocardiogram, a transesophageal echo, exclude a clot and electrically cardiovert, or you need to anticoagulate them for 3 weeks and then cardiovert later. Any questions from that? Please ask if you don't understand. Okay. If once you have cardioverted, right? Arrow once you have cardioverted, some people need long-term rhythm control also. Long-term rhythm control. And this decision is made by a cardiologist, not by you. Some people need long-term rhythm control. What are the options of long-term rhythm control? Beta blockers work sometimes. Standard beta blockers work sometimes. For long term, once you have established the rhythm, beta blockers can maintain it long term. So these are long term, right? Other options are amiodarone. If they have left ventricular failure, heart failure, there's a new drug called dronedarone. Important things are, you can also use this sort of flecainide propafenone, but they are contraindicated in patients with ischemic or structural heart disease. That is an MCQ point. Right? Flecainide if they have ischemic or structural heart disease. Right. So I'm just going to go through with you rhythm control strategies in persistent AF again. Duration more than 48 hours, not on therapeutic anticoagulants. You can do two things: echo, transitional echo, and cardioversion or anticoagulation later cardioversion, right? If they're on anticoagulants, no problem, cardiovert them. And these are electrical. Once you have achieved sinus rhythm, long-term rhythm control can be achieved with a beta blocker, or if they have other sort of comorbidities, amiodarone is a reasonable thing to do. Don't use flecainide or propafenone when they have ischemic or structural heart disease. Very important. Now, if they are paroxysmal AF, just you might put them on a drug just for long-term rhythm control. AF, paroxysmal AF, right? Long-term drug beta blocker, amiodarone, or any of these. Right. If the rhythm control strategy fails completely, there are other options like ablation. Okay. Right. Any questions? Any questions, Lamai? Please ask. Amaru area.
Sir, do we need anticoagulation further if we correct the rhythm, sir?
Yes, I will talk about that in a minute. So what Achala is asking is, do you need long-term anticoagulation once you get them back into sinus? I'll answer that question in a minute. Right? Right. Right. So no, you don't need to know about cardioversion. That's cardiology. So anticoagulation, I'll tell you. Just give me a minute. Right. Right. Now, in acute AF, acute emergency medicine presentation, acute AF, slowly slightly different. And I taught this to you in your emergency medicine. If they have acute AF, you have to see if they have any of the adverse signs, say features of hemodynamic instability or acute heart failure. Adverse signs hemodynamic instability, acute heart failure. If they have hemodynamic instability, you have to give them DC cardioversion. No problem, no kata, no sina. That is the treatment. If they are stable then you have an option between rate control or rhythm control, right? You have an option, and most of the time we do rate control in the emergency department, right? Most of the time, and refer them to a cardiologist for further management, right? එතනින් එහාට ඒක ගැන මහලුකුවට දැනගන්න අවශ්‍ය නැහැ, right? Okay, fine. So what is the answer here then? So this is acute presentation, acute presentation, and you can see the patient has extensive bibasal crackles. There is thyrotoxicosis, which is driving the thing. So this patient has acute heart failure, severe AF. What is the treatment here? No doubt, but DC cardioversion. So remember then, may flow chart acute AF. If they have new onset AF, hemodynamic instability, acute heart failure, carry out emergency electrical cardioversion without delay, right? Important. Hari? Electrical cardioversion, sorry, anticoagulation, sinus rhythm. Hari? So that is very important. Hari? That is very important. If they have new onset acute AF without life-threatening problems, then you have an option, rate control or rhythm control. Right, and you usually get cardiology. Rate control cardiology opinion. So here there is no doubt that you need to cardiovert the patient because the patient is in a life-threatening AF with acute heart failure. Okay, right. Now let's talk about anticoagulation in AF. Yeah, so let's talk about the last thing I need to tell you about AF is anticoagulation in AF. Anticoagulation. Right. Now, anticoagulation in AF is indicated in several things. Number one. If you are cardioverting anyone with a duration of AF more than 48 hours. So you need to anticoagulate them. If you are so write this down very carefully. Or usually these come in a single best response MCQs. So anticoagulation AF is indicated, number one, when you cardiovert somebody with AF lasting for more than 48 hours or duration uncertain. Anticoagulate curve. And this anticoagulation should continue for about 3 weeks, 2 to 3 weeks. Why? When you cardiovert AF, the atrium is stunned. And there you can get transient clot formation. There might be already clots also, but there is a transient increase in clot formation, right? Moment you give a DC shock, transient increase in clot formation. So in order to cover that transient thing, you have to give them a, say, 2 to 3 weeks of anticoagulation when you cardiovert them. So that is important. Second indication is in the long term also, we might anticoagulate people in the long term, right? In the long term. In the long term, anticoagulation, long term anticoagulation is based on the CHADS2 VASC score. Long term anticoagulation is based on the CHADS2 VASC score, right? CHADS2 VASC score, මේක තමයි තියෙන්නේ. නිකන් ඔක බලා ගන්නකො CHADS2 VASC score, heart failure, hypertension, age, diabetes, previous stroke, transient ischemic attack, vascular disease, එහෙම තියෙන්නේ. හරි? CHADS2 VASC score. Right? Or if they have mechanical heart valves, moderate or severe mitral stenosis. දැන් බලන්න මේ algorithm එක බලන්න. Mechanical heart valves, moderate, severe mitral stenosis. Yes, definitely you need to anticoagulate them. හරිනේ? And that is with warfarin. BKA කියන්නේ warfarin. හරි? Vitamin K antagonist, warfarin. If they don't have it, you use the CHADS2 VASC score, and this is called non-valvular AF. හරි? And then මෙතන guidelines තියෙනවා. 0 නම් nothing. 1 නම් oral anticoagulation considered. ගොඩක් අයට දෙනවා. Right? 2 or more, definitely yes. Right? Definitely yes. So දැන් කියන්නේ මේ DOAC දෙන්න කියලා or warfarin. Right? If there is valvular, definitely warfarin. If there is not a valvular problem, you have an option, DOAC or vitamin K, warfarin. Make ඕන නම් දැනගන්න, if you have contraindications for anticoagulation, ඔගේ දාන්න පුළුවන් net එකක් වගේ දාන්න පුළුවන් atrium එක අස්සට. Right? Atrium එක අස්සට net එකක් වගේ දාන්න පුළුවන්. So අර මේ IVC filter දාන්නේ in pulmonary embolism. Something similar, you can put a sort of a mesh into the left atrium so that the clots don't break off. හැදුනත් ගැලවිලා යන්නේ නැහැ. Right? That's called a LA occluding device. LA occluding device. හරි. Right. So දැන් මම ඔයගොල්ලන්ට උගන්වුවා මම ඔයගොල්ලන්ට emergency medicine කරනකොට ඉගෙනුවා acute AF manage කරන විදිය. So ඒක මම ආයි කියන්නේ නැහැ in detail. Right. What I did today in detail was more of non-acute AF presentations, rate control, rhythm control, decide කරන්නේ කොහොමද, and also about anticoagulation. So 2 indications. One, for a short period of time, if they have been cardioverted because of this stunning of the atrium and the risk of clots. In the more longer run, if they have mechanical heart valves or moderate severe mitral stenosis, yes, with warfarin. If no, assess their chance to best score. And if it is 1, you might give them ගොඩක් අයට දෙනවා. 2 or more, definitely yes. Option is either warfarin or NOACs if you like an apixaban වගේ ඒවා. If they are contraindicated, you can put a mesh into the left atrium to prevent clots from breaking off. Any questions about those? Ahanna, please. So in short-term anticoagulation, so after the, again, around the cardioversion, you need to start. Right? Short-term anticoagulation. Hari. Then බලමු මේ MCQ can this will further solidify your knowledge, hopefully. In atrial fibrillation, stable patients with atrial fibrillation, immediate electrical cardioversion is the preferred treatment option is false. Ne? That is wrong. Right? So stable patient name, immediate electrical cardioversion is the preferred treatment option. Never. That is false. Digoxin is the preferred agent for controlling the ventricular rate. Nani man kiwa the ventricular rate control karana main things are beta blockers, calcium channel blockers. If digoxin is used if they are sedentary or they have heart failure. Right? That is when you use digoxin. All patients with AF should be commenced on anticoagulation. වැරදිනේ all patients with AF anticoagulation කරන්න අවශ්‍ය නැහැ. දැන් මම පැහැදිලිව කිව්වා. කවර හොයලාද anticoagulation if you are rhythm controlling cardioverting somebody short term. 2, if they have mechanical heart valves anammanang definitely yes, right? Or tight severe mitral stenosis. And then if the chance risk is high. So not all patients will be anticoagulated. Aspirin is an effective alternate to oral anticoagulation. Nani aspirin ගැන කතා කරන්නවත් නැහැ. There is no use in using aspirin as an alternate. No point. Absolutely no point. Long-term rhythm control strategy has better outcomes than rate control with anticoagulation. Right? There is no major difference in a long-term rhythm control strategy versus anticoagulation and rate control, right? There is no difference. Sachin is asking an interesting question. Mitral regurgitation, the evidence is not as strong. Ekai me guideline එක MS කියලාම කියන්නේ. හරි? So this MR also, yes, maybe in the same way, but the strongest evidence is for MS, not MR. හරි. Right. So ඒක හරි. Fine. Right. මේකත් බලමු. 80-year-old woman was admitted to the ward with dizziness, monitoring initially with atrial fibrillation, rapid ventricular response. Her ventricular rate was continued with beta blockers. Echocardiogram revealed an enlarged left atrium with an ejection fraction of 50%. Right? මොකක්ද මේකේ හොඳම strategy එක? What is the best strategy here? So this is a patient දැන් අපි long term management ගැන හිතන්න ඕනේ. What do you think? Okay, look at this. Offer rate control as a first line treatment strategy unless AF has a reversible cause. There is no reversible cause. Patient has heart failure thought to be caused by AF. Patient ejection fraction is 50%, diastolic dysfunction. Person has new onset AF. No, they can't clearly say new onset AF here, right? If that is the case, rate control is better. Rate control is better. Okay, so this patient, you would do rate control and probably anticoagulation because the CHA2DS2-VASc, if you calculate this patient, the CHA2DS2-VASc is high. So the answer is 5. All right. දැන් ඒ ගැන මොනවා හරි AF ගැන මොනවා හරි ප්‍රශ්න තියෙනවා නම් අහන්න. So AF management, acute AF is different to chronic AF. Acute emergency presentations of AF slightly different in your management options, right? If they come to the clinic, this is how you manage and this is how you anticoagulate. මේ flow charts ටික මතක තියාගන්න ඕනේ හරියට. හරිද?
Excuse me, sir.
Yes.
Sir, acute AF කියන එකයි අර මේ අර non acute presentation එකේ new onset කියන එකේ වෙනස මොකද්ද?
Acute AF උයි
non acute presentation කියන එකේ අර new onset AF කියන්නේ
new onset කියන්නේ හොඳටම sure වෙන්න ඕනේ මේක අලුතෙන්ම ආපු එකක් කියලා. That is a very specific thing, right? You have to be absolutely sure it is new onset, right? Acute AF can be patient who has had AF but suddenly comes with a worsening. ඒකත් acute නේ. New onset කියන එක sure වෙන්න ඕනේ. කවදාකවත් AF තිබිච්ච නැහැ කියලා sure කෙනෙක්ගේ and that is most often very difficult to say. හරි? හරි දෙක තේරෙනවද?
Oh, sir, thank you.
Okay, so මොකක්ද ලොකු කතන්දරයක් මේක දාන්නේ. So somebody had asked a few questions about do you need to anticoagulate in paroxysmal AF also? Yes. Then that is evidence to say, that's a bit of a difficult question, but evidence to say that even if you have had one episode of AF, if your CHA2DS2-VASc is high, you need to anticoagulate. So paroxysmal the මොකක්ද කියලා වැඩක් නැහැ. Anticoagulation either if it's valvular or non-valvular, you need to anticoagulate. Right? So මෙතන මේ best response එකක් දාලා තියෙනවා. Best drug to prevent future stroke. නේ ඒකේ අහලා තියෙන ඒකනේ. එතකොට so blurred vision නෑ sorry ඔයා දෙකක් එතන දාලා තියෙනවා. 76-year-old male එක definitely warfarin prevent future stroke වෙනේව කළා හරියන්නේ නැහැ නේ anticoagulate කරන්න ඕනේ. ඒක හරි. ඒක anticoagulation. So dizziness is not an acute presentation because acute presentation, again, acute things are acute left ventricular failure, syncope, right? Hypotension. Acute. Dizziness is not a sort of acute presentation or emergency presentation. Right. All right. So the next thing is SVT, paroxysmal SVT. And this is an ECG. So remember this arrhythmia, it's a narrow complex tachyarrhythmia. There are various names which are used for this arrhythmia. We call it SVT, we call it junctional tachycardia, nodal tachycardia, right. This is most often due to an accessory pathway connecting the ventricles to the atrium. That's wrong, right? The accessory pathway, Wolff-Parkinson, right? That causes slightly different type of arrhythmia, right? That is not the here. There is a very small circuit around the AV node, a normal circuit around the AV node. That is what the etiology is, right? Okay, the second statement is very easy. As you know, here the arrhythmia arises from above the ventricles. So therefore, it is narrow complex by definition. Narrow complex by definition. Narrow complex. Broad complex. Now, again, in your emergency medicine classes, we have talked about the management of this. So first line is vagal maneuvers. Remember, vagal maneuvers. These are all if the patient is stable. Remember, vagal maneuvers. And if vagal maneuvers fail, adenosine is the drug of choice. Adenosine. So vagal maneuvers are contraindicated is false. That is primary treatment option here. Intravenous calcium channel blockers are first line therapy. Is Baradi. What is the first line therapy? Adenosine. Calcium channel blockers are indicated only if either you don't have adenosine, right? Or if adenosine is contraindicated. Adenosine is contraindicated in patients with asthma, right? MCQ adenosine is contraindicated in patients with asthma. Adenosine. Hari. Flecainide. The whole flecainide gana kalimma kiyala in AF, ne? So flecainide is a good sort of long-term rate control option, rate and rhythm control option, but it should not be given in AF. It should not be given in ischemic or structural heart disease. So flecainide is a good antiarrhythmic. It can be used for SVT also sometimes, but it is contraindicated in patients with ischemic or structural heart disease. General contraindication, flecainide. False. So SVT is an easy thing to manage. Vagal maneuvers, adenosine, calcium channel blockers only if adenosine is not available or there is a contraindication for adenosine. That is the thing. Hari. Any questions? Yes. So Chandra is asking, if a patient present MI and we detect AF, yes, Chandra. So emergency medicine when you have acute presentation of any sort of tachyarrhythmia, there are 4 features which indicate urgent cardioversion. One is acute left ventricular failure, syncope, hypotension, or clear evidence of myocardial ischemia, right? So that is all those are indicated for cardioversion, right? Is there a different entity as paroxysmal SVT? SVT, paroxysmal SVT, everything refers to the same thing. Paroxysmal AF, persistent AF, it just persists for a long time. Paroxysmal AF, in SVT, most of it is paroxysmal. Right? Right. Okay. Right. Now, question number 4 is asking you, and this is slightly bit more technical, about this. Right. Now, remember I told you in the classification of tachyarrhythmias, you have narrow complex tachyarrhythmias and broad complex tachyarrhythmias, right? Narrow complex tachyarrhythmias, broad complex tachyarrhythmias. And I told you that the narrow complex tachyarrhythmias, what do? Narrow complex, those are ones arising from above the ventricles. Atrial fibrillation, atrial flutter, SVT, all of those are narrow complex. Broad complex tachyarrhythmias are often ventricular in origin. They are ventricular in origin. However, broad complex tachyarrhythmias can also arise if there is a rhythm arising from above the ventricles, but there is a block on the way. Block there's a block on the way, right? So that can also give rise to a broad complex tachyarrhythmia, right? So there are two causes of broad complex tachyarrhythmias. One is ventricular. Two is stuff coming from above, but there is a block, usually a bundle branch block. Right? This slide gives you the differences between a ventricular tachyarrhythmia, ventricular tachycardia most of the time, versus a arrhythmia arising from above the ventricles with a block, right? Make a essential name of නිකන් MCQ එකක් දැම්මේ ඔයගොල්ලන්ට නිකන් මේක තියාගන්න for reference. ඔබ සාමාන්‍යයෙන් අහන එකක් නෙවෙයි, but නිකන් බැරිලාකත් ඇහුවොත් එහෙම these 5 features I would tell you මේක අනිවාර්යෙන් ventricular. This is not a supraventricular with a block කියලා කියන්නේ. හරි. එතන given. So for example, extreme axis deviation with a very broad QRS complex indicates that it is a ventricular, right? AV dissociation. So AV dissociation, sometimes on the ECG, you can see that the P waves and the QRS complexes are not related. Right? They are not related. Because when you have a ventricular arrhythmia, there is no relationship between the ventricular response and the atrial response. Then also you can see these funny things called fusion beats and capture beats. This is not a very important question for yeah, don't worry too much about this. Okay, right. Now that's all about tachyarrhythmia. So most important is atrial fibrillation. Atrial fibrillation. Okay. Then matter make this one. Now when it comes to bradyarrhythmias, all I taught you this. This algorithm. So here also, when you have a bradyarrhythmia, you look for adverse features like shock, syncope, myocardial ischemia, or heart failure. Right? If there are any of these adverse features present, you give them atropine. Full dose of 0.5 milligrams. If there is a good response to the atropine, right? No problem, observe. But if it doesn't respond, there are other options, right? Other options are atropine. You can continue up to a dose of 3 milligrams, right? 3 milligrams. Or you can do other things, right? Now, even if they don't have adverse features, there are 4 bradyarrhythmias which have a high risk of asystole. These 4 bradyarrhythmias have a high risk of asystole, right? These 4. And they should be treated in a similar way as the unstable ones, right? One of the hatara, recent asystole, Mobitz type 2 AV block, complete heart block with broad QRS, and ventricular pauses. Right? So these ones need to be treated as for a unstable patient. Okay, right. Okay, so let's talk about the last MCQ is on complete heart block. Abhi pericardial disease ඊගාව දවසේ කරමු. හරි. Right. So last MCQ is on heart blocks and specifically on complete heart block. Right. Irregular Canon A waves can be seen on the ECG. ECG නෙවෙයි මේක වැරදි, sorry. Canon A waves clinically මේක මට වැරදිලා එතන. Okay. ඒක වැරදි ඉතින් ECG A waves වෙන්නේ obviously. Right. So what are these irregular Canon A waves? What are these? Now what happens is in complete heart block, as you might remember, the atria and ventricles work out of sync. They don't talk to one another. Ventricles work in their own way, right? Atria work in their own way, right? There is no coordination at all. There is no coordination at all. Right. Sometimes what happens is the atria and ventricle contract at the same time, right? The atria and ventricles contract at the same time, causing a massive increase in the left atrial pressure. Massive increase. Right atrial pressure. Massive increase. Dekam ekapata contract වෙනවා. Atrium එකයි ventricle එකයි contract at the same bloody time. And then what happens is a massive increase in the right atrial pressure, and that gives rise to a Canon A wave. Canon A wave. Canon A wave. So that is that. Right? Because they don't talk to one another, සමහර වෙලාවට they contract together and cause a Canon A wave. Canon A wave. Presence with syncopal attacks කිව්වනේ මතකයි නේද අපි කිව්වා. In this algorithm, there are 4 important, urgent, unstable manifestations of bradyarrhythmia: shock, syncope, myocardial ischemia, and heart failure. Ne? Yes, they can present with syncope. Complete heart block with a narrow ventricular escape rhythm has a poor prognosis. Poor prognosis. ඒකත් හරි, because මේකත් මතක තියාගන්න. There are 4 high risk ECGs. Even though they are stable, you still have to worry about. And that is complete heart block with a broad QRS. I mean, why is it an unstable thing? Now let me explain that also. Why are we worried about that so much? Why is this? Right. Now when there is a complete heart block, there is no current coming from the atrium into the ventricle. Ne? That is what happens when there is a complete heart block. There is no current coming from atrium to ventricle. Current take a block. What happens is the ventricle starts generating its own rhythm. Ne? Because heart has to keep on beating, the ventricle generates its own rhythm. And this is called an escape rhythm. Escape rhythm. Escape rhythm. Escape rhythm. It starts generating its own rhythm. Escape rhythm. Right. Now, the broader the escape rhythm, that means it is arising from the ventricular muscle. ඈතට යන්න ventricular muscle එකෙන් තමයි මේක පටන් ගන්න. Broader වෙන්න ventricular muscle එකෙන් තමයි මේක පටන් ගන්න. If it is narrow, it is arising close to the AV node. This escape rhythm, if the QRS complex is narrow, that means it's arising from very close to the AV node. But if it's broad, it means it is arising from the ventricular muscle, which is හොඳ නෑනේ ventricular muscle එකෙන් heart rate එක maintain කරගන්න බෑ. The maximum it can give you a signal is about 30 per minute. ඊට වැඩිය බෑ, right? So broad QRS complex means the rhythm is arising from the ventricular muscle, which is very slow and not very strong. Right? So ඒක හොඳ නෑ. That is why it is unstable, poor. That is why it is unstable, poor. Right. Then fourth one, dissociation of P waves, QRS complexes. අපි කතා කරලා තියෙනවා කලින් complete heart block අපි ECG classes කරනකොට. That is an important feature because these two don't work together තමයි ඒවා එන්නේ. And as a consequence of that, the first start sound intensity also can vary. මොකද මේක කිසිම පිළිවෙලකට නෑනේ first start sound closure. Because atria and ventricles are not working together, the first start closure is irregular and එක එක වෙලාවල් වලට එක එක දේවල් වෙනවා. Right? So that is the reason for this first start sound problem also. Right. So that is that. Right. So third step before it. Yes. Narrow ventricle has a poor prognosis. Narrow ventricular escape rhythm එක හොඳයි. Right? Narrow ventricular escape rhythm එක හොඳයි. Because then it is arising from the escape rhythm, which is maintaining the heartbeat, is arising closer to the AV node. හොඳයි නේ එක උඩ හරියෙන් එන එක. පල්ලෙහා හරියෙන් එනකොට broad වෙනවා වෙන්න. ඒ කියන්නේ ඒක ventricular muscle එකෙන් පටන් ගන්න. Ventricular muscle එකෙන් පටන් ගන්න එක හොඳ නෑ. It can't maintain a good heart rate. හරිද කි? Okay. ගීත හරිද ඒක? Okay, fine. Right. ඒකට දැන් අපි අද ගොඩක් එක එකව කරා. Right? So valvular heart disease, congenital heart disease, tachyarrhythmias, bradyarrhythmias. Is there any question you want to ask, especially AF ගැන මොන හරි ප්‍රශ්නයක් තියෙනවද? So acute management එක අපි කලින් කරලා තියෙනවා. This is today I discussed a little bit more in detail about sort of more non-acute presentations where we sort of discuss a little bit more detail acute and anticoagulation, right? ප්‍රශ්න මොනවද තියෙනවද තව? හරි. දැන් ඔයගොල්ලන්ට study leave හම්බෙනවනේ ලබන සතියේ. Right? Now what we should do is you should study now. Other subjects උත් තියෙනවා. But මම ඔයගොල්ලන්ට දැන් I will post the next MCQ paper that we can do next Sunday, that is ischemic heart disease and a little bit of pericardial disease. ඒක ඉවර කරලා then you be going to your study leave. So please sort of make sure that you do all the questions before coming to the session at the තේරුමක් නැහැ, and you can study in parallel. So අපි respiratory පටන් අරගෙන respiratory එක කරලා දාමු. ඒ වගේ. So then you can study in parallel, make sure you answer everything and come. Then it will be much, then you don't need to study it again. Right? Discuss කරාට පස්සේ ආයෝග අමතක කරන්න. I usually include MCQs to cover all the sort of important areas so that you don't miss anything. Right? Past papers උත් කරන්න, but yeah, this will be sort of a more structured process as well. Right? Right. Sarangani හරිද එහෙනම්? Is that okay? Next Sunday then, eh?
Okay, sir.
Right. I'll put the paper today and then you can do it before then.
Yes, sir. If we are going to do it more often, sir, when will it be?
Yeah. So what I'll do is I'll put මෙහෙම කරමු. So on next Sunday, I will put the whole of the respiratory thing and we'll work through it over the week.
Okay, sir.
Right? අපි ලොකු ඒවා ටික කරොත් දැන් පොඩි ඒවලට සතියක් යන්නේ නැහැ. We will just go through there'll be about say per topic about 15 or 20 MCQs. We can work through it over the week, right? And tell me what the best time is also to do.
Okay, sir.
Right?
Okay, sir.
Because we need to get it done in finish it in February. Just
But
tell
the
me what
week
time
has,
is.
like weekdays also, no, sir?
Oh,
Okay.
we'll do, because I don't have the professorial students also, so I have more time then. කරන්න පුළුවන්. Right? It all depends on how you sort of organize yourself studying as a batch. පොඩ්ඩක් ඒ වෙලාව පොඩ්ඩක් free තියාගන්න to discuss.
Okay, sir. I will ask
Hi.
that.
Hari. Okay. Right. Okay. I'll see you next week then. Hari?
Thank you, sir.
Thank you.
Thank you, sir.
Okay. Bye.
Thank you, sir.
Thank you, sir.